Good morning. I would like to speak about the role of the electrocardiogram in acute coronary syndromes. Is it easy to use? Well, let's say there are something in ECG who are quite easy to understand and more or less on-off decision. There are other things who might be a bit more complicated. Is it important? Yes, it is. You will see that the ECG is in almost all algorithms of acute coronary syndrome, one of the big decision maker on top of every pathway, just after the clinical setting and examination. Is it new? Not really. We know since 1920 what happens on an electrocardiogram if you obstruct a coronary artery. It's the typical evolution of myocardial infarction with initial ST elevation, then T negativation and development of Q waves. ST elevation specific for acute coronary syndrome, yes or not? In a very unselected population, probably not. You see here quite an older study, bit more than 100 unselected chest pain patients with formal ST elevation of more than 0.1 millivolts. 25% did not have myocardial infarction, so this is throwing a coin. That's why the actual criteria we use is that we want to have ST segment elevation in 2 contiguous leads with a typical aspect of more than 0.1 millivolts, and the criteria are refined for V2 to V3 with other thresholds. Here, a bit more complicated in men than in women. And these criteria are valid only in the absence of left ventricular hypertrophy or left bundle branch block. So this is quite old, we all knew, is there changing diagnostics? With the electrocardiogram we know now since almost 100 years. Yes, there is. I think when we speak nowadays about ECG, we should have a look at pre-hospital ECG with telemetric devices to have a look at them. Here you see the example of an ECG on a smartphone. Is this something that has impact on our process of care, and does it make sense to do pre-hospital ECGs? You see here a graph you all probably well known as what factors do you prone to get less likely reperfusion therapy. These are the usual suspects: diabetics, female, older aged patients, and they all have less likely to receive reperfusion therapy. Is there also something who can make it more likely to receive reperfusion therapy in acute coronary syndrome? Yes, there is. It's a pre-hospital ECG. So looking at process of care, we think it makes sense. Does it have an impact on mortality? Same study, and you can say yes, it has. You see in a total population, which is actually quite big, more than 100,000 patients in a retrospective analyzed cohort, that you see that the mortality in hospital is 4% versus 4.7%. So you have the same trend also in STEMI as in non-STEMI patients, where you have also a mortality benefit. Looking at this, can you say the quicker the better? Should we activate the cath lab directly from the ambulance? There was this one study who had a look at this. What we can say is we got definitely shorter mean door-to-balloon times of 15 minutes time gain, which is quite substantial. But on the other hand, the in-hospital mortality in this small study was even higher, so had definitely no positive impact on them. And what I think is especially interesting, false positive activation, almost 8% more than by an activation over an emergency department. Brings you to the fact that probably you will get in a system like this a 10% false positive activation of the cath lab. Think about it. Repolarization abnormality is not related to ACS. Also here, We spoke before about ST segment elevation. We have other classical signs like negative T waves, ST segment depression, prominent T waves. But what we have to know is that there is a broad differential diagnosis of all these formal electrocardiographic conditions. Let's have a deeper look at these typical signs. Negative T waves. It's not specific for ACS, but what is nowadays well known that we have distinct patterns of T wave inversions depending on the clinical condition. Here you see in blue acute coronary syndromes, acute pulmonary embolism, and Takotsubo cardiomyopathy. As you see very nicely here, in ACS, there is rather negative T waves in the anterior wall leads, whereas in acute pulmonary embolism, it's the right precordial leads, and in Takotsubo cardiomyopathy, it's more all over the heart. So these are distinct patterns depending on the clinical setting. ST depression, other classical sign. We know that the more pronounced the ST depression is, the worse the prognosis. And this is not only in the first 30 days, this is up to mid to long term. Data from the Paragon study. So what about atypical ECG presentation? We realized in the last years that besides ST elevations, T negativations, ST depression, we also have some conditions where the ECG diagnosis gets quite tricky. These are bundle branch blockers, ventricular paced rhythms. Very important category of patients is the patients with persistent ischemic symptoms, but without diagnostic ST segment elevation. We have the posterior ischemia. We have the famous AVR lead. Let's have a look at them. Left bundle branch block, ventricular paced rhythm. It's tricky to diagnose myocardial infarction in these electrocardiographic conditions. What we have, as you may all know, the Scarbossa criteria, revised Scarbossa criteria also. For me, quite complicated, but what I do usually, I start with the most easy criteria. If the elevations are much too big, let's say more than 5 millimeter ST elevations, discordant to the QRS complex, you have in most conditions quite good probability of MI. And then you can go backwards up there. Are these criteria valid? Well, the literature is controversial. There are studies who document a poor performance. There are studies who document a very good performance. If you see this study, 190 patients, poor performance. Here, 200 patients, good performance. When you compare these kind of studies, you see very nicely that on good performing studies, you have a very much more selected population with a higher amount of myocardial infarction within this population. For me, the conclusion here is quite clear. If you have a well-selected population, then the criteria are valid. If you do it just formal in an algorithm without pre-selection, then these criteria will not perform very well. Next, atypical ECG presentation, the posterior ischemia. You have to realize that with a 12-lead ECG, you have a blind spot on the heart. And this is usually the posterior wall. You see this here on this slide quite nicely. If you have your leads for inferior, for anterior wall, you here have the posterior wall of the heart, which is not depicted directly by the electrocardiogram. What can you do? You can have a look at reciprocal leads, or you can put additional leads to get a look at this blind spot. These are the leads V7 to V9. How does that look? ST depression, the reciprocal changes from the posterior wall in V1 to V3, typically with per-terminal positive T waves. If you have this kind of picture, go for V7 to V9. Okay, then the ST elevation in AVR. You see the ECG is definitely not normal. We have ST elevations only here, a bit more than here, and quite diffuse ST depression all over the ECG. This is something that is known as an ischemic left main or left main equivalent if you have an ST elevation in AVR in combination with some additional criteria that are noted here. So, is this valid? Is this specific? Do we always have a left main occlusion when we have an ST elevation in AVR? No, we don't. Even if you take diffuse ST depression, ST elevation in AVR, then you will still have, when you get an angiogram of this patient, no significant coronary artery disease in 26% and the left main occlusion only in 24% or the 23%. So it's not a very specific pattern. And again, for criteria like this, use it only in a well-selected population. As a take-home message, ECG in ACS, keep your eyes open, consider typical and atypical ECG presentation and always put it in a clinical context. Thank you for your attention.